This week, we're investigating how to differentiate wide complex tachycardias. Our previous work revealed that a wide QRS complex could be due to a ventricular pacemaker site or a block in the high-speed conduction network connecting the AV node to the Purkinje fibres. If the pacemaker site is in the ventricles, then a wide complex tachycardia is going to be a ventricular tachycardia. However, if the rhythm's origin is in the supraventricular area of the heart and there's a bundle branch block, the rhythm is going to be a supraventricular tachycardia with aberrancy, something we abbreviate to SVTA. When confronted with a tachycardia with a wide QRS, we need to apply the skills that will help differentiate between these two things. You may note that I said help. That's because there's no one utterly conclusive ECG or clinical feature that guarantees whether a wide complex tachycardia is VT or an SVTA. Instead, it's essential to look at a cluster of characteristics that say which of these two things is the more likely. A significant starting point in this process is knowing that 80% of all wide complex tachycardia are ventricular. Another defining characteristic is that ischemia and age both favour the presence of a ventricular tachycardia. Beyond this, there are ECG characteristics and algorithms that assist in determining whether or not a wide complex tachycardia is ventricular. This week's learning material will focus on this aspect. However, from a clinical perspective, it's more important to recognise the severity of the patient's presentation than it is to undertake an in-depth analysis of the rhythm's genesis. Undelayed electrical cardioversion is the treatment for the severely compromised patient, regardless of whether the tachycardia is an SVTA or VT. And having recognised this, paramedics should not impede treatment by engaging in lengthy or further differentiation of the nature of the rhythm. The treatment for wide complex tachycardia falls into three broad groups. The first and the most serious is when a patient with a wide complex tachycardia cannot obey a command. Should the tachycardia be considered the primary issue, the immediate course of action is a crash cardioversion. The treatment is the same for VT and for an SVTA. Cardioversion is critical because it's a life-saving manoeuvre, and to all intents and purposes the patient is in a peri-arrest situation. So, regardless of the genesis of the wide complex tachycardia, patients with overt hypoperfusion and a severe alteration in the level of consciousness need immediate electrical cardioversion. The second group will have severe hypoperfusion characterised by markedly abnormal vital signs. The distinguishing feature of this group is that they can obey a command. Best practice and the CPG in Aotearoa make it clear that the ability to obey a command is the line in the sand for differentiating which patients will receive sedation before cardioversion. So to reiterate, if the patient cannot obey a command, the assumption is the patient is in peri-arrest and needs immediate cardioversion. If there is severe compromise but the patient can obey a command, this does not indicate peri-arrest, and it's far more humane to administer sedation before the cardioversion, and the sedation for paramedics will be a rapidly acting dissociative agent such as ketamine. When dealing with less severely compromised patients, it's appropriate to differentiate between wide complex tachycardias because the treatment will differ between VT and SVTA. Should a patient with hypoperfusion characterised by somewhat abnormal vital signs that have not impacted the patient's level of consciousness and are in VT, we would go ahead and give sedation and cardioversion. Conversely, should the rhythm be an SVTA, the modified Valsalva manoeuvre is an appropriate course of action. The third group is with those with less severe symptoms. In the case of an SVTA, consensus favours using the modified Valsalva manoeuvre. It stimulates the parasympathetic system and offers a low-risk way to terminate tachycardia. The second line of defence is adenosine. Whilst effective, it can have some unpleasant side effects and does pose a risk to some patients, so it's reserved for the moderately impacted patients. In the case of those with VT and they have a mild to moderate compromise, the first line intervention is again pharmacological, and it will involve IV amiodarone. To complete this week's work in Moodle, you need to review the package on ECG characteristics that help differentiate SVTA from a VT. The other links will access research regarding the benefits of the modified Valsalva manoeuvre, as well as a demonstration of its execution. You can refresh your knowledge about the mechanisms of action for cardioversion agents such as adenosine and amiodarone and the CPGs, and the pharmacology section here in Moodle. If you've got any questions about this, please contact one of the team, and in the meantime I hope you enjoy this week's study. Ka kite.